PPH clinical interventions. Our first presenter is Jennifer Blum. Ms. Blum received a BA in French Literature and Political Science from the University of California, San Diego, and is a graduate of the School of Public Health of the University of California, Los Angeles. As a senior program associate at Genuity Health Projects, she conducts research on misoprostol for a range of reproductive health indications, including induced abortion, incomplete abortion and miscarriage, and management of PPH. Before joining Genuity, she was a staff program associate at the Population Council, where she was involved with clinical studies of misoprostol for a range of reproductive health indications. She was a Peace Corps volunteer in the Republic of Guinea, West Africa, and worked on adolescent reproductive health issues at the Pacific Institute for Women's Health. Please welcome Ms. Jennifer Blum.
Yes, and company.
Good morning. I'm going to try it this way until he wakes up, and then someone else will take over. So like everyone else, I have 10 minutes to talk about a lot of things. Okay. So, the title of my presentation, Misoprostol for Postpartum Hemorrhage Treatment. So here we're shifting a little bit to treatment. We've been talking a lot about prevention. What I'm just trying to summarize really what we know, what we don't know, and what this might mean for programs addressing the treatment of postpartum hemorrhage. So what do we know? We know that misoprostol is increasingly used and available really for all indications, but I wrote PPH treatment in here since that's the topic. And that the early stigma that many of us found who've been working on this drug for over a decade about the drug being used to induce abortions at the wrong regimens or being used for uterine, for induction of labor at the wrong doses, a lot of that early stigma has lessened with increasing information and evidence about the way it can be properly used for the management of postpartum hemorrhage. So I think the international view of the drug has also changed, and that's facilitated efforts towards making it be seen more as a women's health product. And we have some new supportive data on the use of miso for PPH treatment from 3 randomized controlled trials that were all published in The Lancet in 2010. So that has been able to answer some unanswered questions about regimens, and I'll be sharing those data briefly. And we also have increasing programmatic experience internationally. And here we have many of the partners today, so Venture Strategies, JPIGO, Pathfinder. I'm sure there are others. Many organizations are now working programmatically to introduce miso for prevention and even treatment of PPH, and I think that helps bolster sort of international experience and comfort with the drug for this indication. We also have, and this is something that has happened over the last 3 or 4 years, some more institutional support from major institutions, including RCOG, FIGO, and ACOG, that all recommend use of misoprostol for PPH prevention and treatment in some circumstances. So even if they're not openly saying you use it all the time for PPH treatment, they do acknowledge that there are certain circumstances and settings in which misoprostol plays a role. WHO's guidelines that came out, I think, in 2008 or 2008-9, they recommend miso for PPH treatment as a third line. So again, it's not up there in the top, but it is listed as an intervention that we can use for PPH treatment, and we should be happy about that. There is, of course, in light of the fact that there are these 3 new RCTs that came out in 2010, a need to update all of the major international recommendation documents. Among these, the Cochrane reviews. The Cochrane review of PPH treatment was done well before any of these RCTs were published. So one of the things that my colleagues are in the process of doing is contacting the writers of Cochrane and seeing what we need to do to stimulate them to start working on a new review to include the new evidence from these RCTs. Another thing is the WHO guidelines for prevention and treatment. Many of us who have been working with Poppy and others in the field have sort of been disappointed with the guidelines on both prevention and treatment, mainly because the prevention ones are very confusing, and the treatment ones, we certainly would love to see misoprostol move its way at least next to or above ergometrine, for instance. So this is also on the plate of WHO as something they plan to do in 2011 or early 2012. So again, these are going to change. So here are the 5 possible scenarios that I could come up with for use of misoprostol for PPH treatment. It could be used first-line treatment after a prophylactic uterotonic is given, first-line treatment after no prophylaxis, as adjunct treatment, which is probably the most common use of misoprostol, last resort, maybe the second most common treatment of misoprostol, and early liberal treatment, which is a new scenario that we've been investigating with some of the partners that are here today, and I'll present one slide on. The first 2 indications, just because of my 10-minute time limit, I'll discuss together. So I'm going to briefly, in 3 slides, go over the results from 2 RCTs that were published in The Lancet in January of 2010. And the purpose of these studies was to determine if 800 micrograms sublingual misoprostol is similarly efficacious to 40 IU oxytocin delivered IV. These were non-inferiority trials for the treatment of primary postpartum hemorrhage. The trials were conducted in 2, they were double-blinded, placebo-controlled trials. Many of you have heard about these in the past. They were conducted in 2 distinct settings, one in which all women were given oxytocin in the 3rd stage of labor, and one in which women were not given oxytocin in the 3rd stage of labor. And I should say that in those hospitals, some of them just didn't have an institutional policy to give oxytocin, so some women did get oxy in those hospitals. They just weren't enrolled in our trial. In total, we screened more than 40,000 women, of which 1,800 went on to have a PPH in 5 countries from 2005 to 2008. And I should also add, we have some very interesting data, adding on to what Deb started to mention, that'll be coming out in a series of 2 to 3 papers. We're working with a PhD student now to look at the relative impact of each of the components of active management from these 40,000 deliveries, because we have individual level data on all those people. And so we're able to suss out a little bit about what do we know about the difference between when IV oxytocin versus IM oxytocin in the presence and absence of controlled contraction and uterine massage. And we've already previewed that data with WHO because, as many of you know, they have a trial also going on looking at this. And so I think together the 2, our data, which is not from a blinded, randomized trial, but along with their data, will be able to tell us a lot more about this. So here's the results from our trial. So for active bleeding controlled with initial uterotonic alone, this left column here, oxytocin prophylaxis, will now remain the same for the next 2 or 3 slides, which is there's absolutely no difference between oxytocin and having your postpartum hemorrhage treated with oxytocin or misoprostol. This has huge implications on how care is managed in a range of settings, because even if oxytocin can be delivered for prevention, there might be a scenario where either oxy or miso might be easier, faster, quicker, whatever, available for treatment. And what we know from these studies is that they both will work exactly the same. In the other column, where no oxytocin prophylaxis is given, which is sort of the proxy, you would say, for scenarios where oxytocin may or might not be available, we did find statistical significance in favor of oxytocin. So if the woman's uterotonic has not been exposed to oxytocin, oxytocin works better. However, 9 out of 10 women did have their active bleeding stop within 20 minutes. So what we sort of can pull out of this is, even if oxytocin is significantly better for PPH treatment, if it's not available, misoprostol sure isn't that bad. Here is the change in hemoglobin. Again, on the column to the left, where the oxytocin prophylaxis was given, we took pre- and post-delivery hemoglobin using the handheld HemoQ kit. We, on individual levels, this is individual level data, and you can see that there's no difference in change of hemoglobin for women who were given oxytocin or misoprostol if they had had prophylaxis. For women who did not have prophylaxis, there's no difference at the 2 gram a deciliter marker, which is commonly used in studies, but at 3 grams, in fact, we did see that there was a preference for women who were given oxytocin. This is the rest of the study on one slide. Basically, no difference in other interventions, but for women who did not have oxytocin prophylaxis, more misoprostol users did need additional uterotonics. So this is, again, something to think about when we get into the program. You might want to be able to make misoprostol available, but you have to recognize that twice as many women in those programs are going to need additional uterotonics. So we still need to have transfers, referral systems, et cetera, in place to be able to manage those cases. Side effects, no differences, large differences in favor of oxytocin, had less cases of shivering and fever. As we all know, there was twice as much shivering and fever amongst women who were given misoprostol. It was able to be managed by nurses with cold compresses, antipyretics. There's a separate paper directly addressing the issue of fever, particularly in Ecuador, where it was most commonly observed, and that reference is in the list of citations that you have. So what are the implications? Misoprostol is clinically equivalent to oxytocin for treatment of primary atonic BPH among women who receive prophylactic oxytocin in the third stage of labor, yet oxytocin is significantly better than misoprostol if the women had not been exposed to oxytocin. However, and this is the big, of course, right? In settings in which oxytocin is not feasible, clearly these data show that misoprostol is a safe and effective alternative first-line treatment for postpartum hemorrhage. And so it's a very powerful evidence-based tool for us to be able to move forward in programs on treatment of PPH. The next scenario is miso as adjunct treatment. This is a trial that Genuity carried out with WHO. I think it came out in June in The Lancet. It was Widmer et al. This study looked at women who are given oxytocin prophylactically as part of management of the third stage of labor. They go on to get a PPH, and then they get oxytocin IV. Half of them got with misoprostol, the other half with placebo. And what we found is, and this is, as many of us know, I'm not a provider, but as many providers I hear from in the field, this is one of the most common uses of misoprostol. Absolutely no benefit. There was no difference in any of the outcomes for the women that got miso and oxy at the same time, except that they had more side effects. So that's unfortunate. Yeah. It's mostly not a good idea if you think you're doing something to reduce the hemorrhage, because you're not. And so you need to be, I think the message for this, for me, is that people need to be prepared to move on to whatever the next line of things they want to do is, rather than focusing on this and thinking that it's going to have a clinical impact. Then we have last resort treatment. Little scientific data, obviously not really feasible or ethical to do randomized control trials. But of course, from what we know about the safety and efficacy and side effects of misoprostol for all the PPH indications, the possible positive effects obviously seem to outweigh the limits, but we need to recognize those, and again, in these situations, be doing all that we can to get women on to additional care. This is a crazy table that we continually try to revise to make more user-friendly. I think the key is that, with the exception of when there's no oxytocin prophylaxis, what we see in all these boxes is either oxytocin or misoprostol can work really well for PPH. And I think this sort of starts to drive home the message that these two drugs go hand in hand for the management of PPH. And this is for a later slide that I was going to say, but I think one of the key things for those of us who are working in this field as program people and as advocacy people is when we go to have our discussions with providers and policymakers and ministries of health, to recognize, to always position the drugs together as complementary and not as one drug might replace one or one thing, because all the interventions, whether it's miso, oxy, or the anti-shock garment, I think this package of interventions is really critical. And what we see from here is that, there's a place for all of these things. Early liberal treatment. I saw Suellen here earlier. She's here somewhere. Oh, see, go out there. Go out here. I was like, where is she? This is an area that we're super excited about, and we've been exploring at Genuity. We've been very interested in this for years, and as has Suellen and Stacy Geller, who many of you know in the audience. And so we're working together with them in India and also with partners in Egypt to explore whether or not early liberal treatment might sort of be the wave of the future. Is universal prevention needed? Do the costs outweigh the potential benefits? We don't know. And this is the very question nobody ever wants to ask, but does universal prevention save lives? We have no evidence that it does. So we're looking at a range of clinical studies where maybe we say don't give prevention to everybody, but if blood loss reaches a certain point, 350, 500, our studies show that many women could lose 700 with no clinical impact. Maybe you give selective treatment to those people, and that might be the wave of the future to have a more cost-effective, realistic, reasonable program. We can discuss that more later. So if this table was in a table, the bullets would match, and then we'd see the list of what we know and what the new research question is related to it. So what do we know? Miso use is associated with fever. What we don't know is if a lower dose would maintain efficacy and lower side effects. Partners at WHO are very interested in the lower dose because of this issue, but we know very little about the efficacy of the lower doses. What we know is miso has been shown to be effective in hospital settings. What we don't know, for treatment at least, is can it be effective when used in community-based settings? We have no information, very little information about this. We have some information, there are a few publications, but at a large scale, we know very little about it. We do know that miso has been shown to work for prevention or for treatment of PPH. What we don't know is what happens when it's used for both prevention and treatment of PPH. And this is a big question because as some programs are moving forward to, give miso for prevention, give miso prevention, what we saw in the oxytocin studies is that the unexposed uterus did better with the oxytocin. So is there going to be a problem with MISO plus MISO? Is the treatment MISO not going to work as well? Are the side effects going to be too huge if you're dosing the women? We don't know. Lastly, MISO, UNIJECT, all the component of Amstels have been shown to be effective in PPH, but we know very little, although we're finding out from our research and the research of WHO and others, what the relative impact is of each of these interventions and how that might affect programs if we find out that the UTEROTONIC alone has the greatest impact. Maybe for certain levels of providers or certain settings, you just train on administration of the UTEROTONIC and you don't need to bother with controlled contraction. I don't know. Well, I have some idea, but I can't talk about it now. Gaps in the evidence. Again, is misoprostol safety profile acceptable for widespread treatment of PPH? We need more information in service delivery models. For the safety profile, this is commonly asked. It's a huge barrier with WHO. Those of you who are involved with the EML application for prevention the last time know WHO has commissioned a safety review that's available on their website now as part of the EML applications that Genuity and Venture Strategies put forth for prevention, and another one for treatment. They've come out to say that it's safe, but it's a problem. We need more information. We need more information in service delivery models to continue to ensure that if we're acknowledging that these deliveries are happening at lower levels of the healthcare system, which I think is good to do, that we're still having methods for referral and everything, that the system is still working. There's some work going on. I mentioned some of the agencies. I think we need to document more of that and make it more available. And that goes along with training and monitoring and continuing to publish more and share more at international meetings about programmatic. And the big unanswered, question in the room, do we know that misoprostol saves lives? I'm not sure. Another big issue is advocacy efforts to make sure that we're all messaging the same thing. Now, part of Genuity's new project on PPH, we're partnering with Family Care International. They'll be contacting many of you. They're planning to host a meeting in the first half of, well, it must be the second half of this year now, right? Because we're in January, on advocacy issues. So they want to get messaging. So they bring together all the people that are working on misoprostol so we can start to have some similar messages about misoprostol, about the regimens, about how it's going to be used. So that's one thing that they're going to be working on. And then to continue to have more operations research, we've heard some of today, whether MISO goes in delivery kits, whether it's home administration, whether it's A&Ms. All these things need to be explored, need to be discussed. And we need to be prepared to answer and respond to questions, and this is again part of, I think, bringing advocacy efforts together, questions as to why misoprostol is recommended by some and not by others. Why do we not understand still the WHO guidelines? Why are certain levels of providers allowed to use it and other levels not? What does this mean? And we need to sort of come together and have a way, because this is a big problem we have when we try to get to the country level. And again, the point I made earlier, all of these drugs and all of these interventions together are a package of interventions. So I think we need to be very strategic in our discussions with partners and ministries of health about how all of the oxytocin, misoprostol, anti-shock arm, and everything work together and not in replacement of one another, because that's never going to be a strategy that's going to help improve the conditions. And that I already mentioned. Thank you. A minute?
A little more. Good. Well done. How could I stop here?
That's awesome.
Wow, in my book, that's quite an achievement. Giving a presentation and finishing it without waking the baby.
We'll see, now he'll wake up. Thank you. Isn't he used to that? Yeah, I talk a lot, so he's used to it.
Our next presenter is Dr. Suellen Miller. Dr. Miller is the Director of Safe Motherhood Programs at the Bixby Center for Global Reproductive Health, Department of Obstetrics, Gynecology, and Reproductive Sciences. She is also the Associate Professor at the University of California, San Francisco. Additionally, Dr. Miller is associate faculty, Associate Professor of the Maternal and Child Health Program at UC Berkeley's School of Public Health. She is an experienced maternal health clinician, having practiced as a certified nurse midwife for over 30 years. She received her PhD from the University of California, San Francisco in 1994. Besides her work as principal investigator of the randomized cluster trial of the non-pneumatic Anti-Shock Garment, Efficacy in Zambia and Zimbabwe. Dr. Miller consults with Pathfinder International's Continuum of Care for PPH project in Nigeria and India. Other reproductive health projects she is directing or participating include Millennium Development Villages in Ghana and projects on the intersection of HIV and maternal mortality epidemics in Kenya. Please welcome Dr. Miller.
Stand on the, yeah, there you go. Wow. Do you want me to time? Yeah.
So forward, backward, and then right to the right. Yeah, right, thanks.
Hi, everyone. Thank you so much. It's really an honor to be here, and I'm so thrilled to be with my so many partners that I've worked with internationally with the Pathfinder PPH project. So I'm talking today and standing in for a huge team of international collaborators. I wouldn't be here with the amount of data. Sudhir kept saying articles and articles and data, and we've managed to get a lot of good data only through the really hard efforts of people who are working in country in Egypt, Nigeria, Zambia, Zimbabwe, and our UCSF team. So just to briefly cover this for people who don't know what the anti-shock garment is, it's a neoprene and Velcro lower body first aid device. It applies circumferential counterpressure, which will decrease further blood loss and reverse shock. So it's an anti-shock garment, and it also reduces blood loss, and is used for women who are already in hemorrhage and have already shown signs of shock. Mechanism of action is very simple. In decompensatory shock, the heart and brain and lungs, our core organs, are deprived of oxygen because blood is leaving the body, as well as pooling in the lower limbs. Application of this device will squeeze some blood up to the core, but will also compress the lower part of the body. In other words, making the container that this less blood is circulating in a smaller container. So decreasing the container size and actually decreasing the radius of the blood vessels, thereby slowing the flow of blood. So in our studies, we have seen 3,609 women who are treated with the anti-shock garment. These studies do not include all of the women who've been treated with the NASG in the Pathfinder project. So these are just the ones who we have meticulously documented every blood pressure, every pulse, every drop of IV fluid in and urine out. That's the data that we have on 3,609 women, and growing every day from our work in Zambia and Zimbabwe, which is ongoing. The NASG studies to date have been done for obstetric hemorrhage, not only postpartum hemorrhage. So pretty much any bleeding that's going on in the pelvis will respond the same to the NASG. So we have been looking at women who have experienced ectopic pregnancy all the way through placenta accreta. So there are multiple uses for this with the different obstetric hemorrhage etiologies. But as we know, the main cause, the main single cause, uterine atony, is about 35%. When we look at women who have entered our studies in severe hemorrhage, in shock, 35% of them are suffering from uterine atony. What I'm going to cover today is combined results from our pre-post intervention studies in both Egypt and Nigeria, concentrating on 6 facilities, tertiary care facilities, and the total number of women treated in these facilities, 1,442. We did this study as a pre-intervention phase, NASG phase study, the only difference being the application of the NASG. So data was collected, blood was collected so that we knew exactly how much blood the women lost during their resuscitation efforts, and the data was collected. For all of the women here, if they were delivering, they received active management of third stage labor with UTEROTONIC, and if they went on to be in the study, received whatever treatment was appropriate, fluid, blood, surgery. At the NASG phase, again, once they entered the study, the only difference was the application of the NASG. The entry criteria for women were women with hypovolemic shock, as we said, any etiology, In Nigeria, we entered women at 750 milliliters estimated blood loss. We waited till over 1,000 in Egypt. But besides the estimated blood loss, these women had one or more clinical signs of hypovolemic shock, either blood pressure or pulse. Our study outcomes was measured median blood loss using the same plastic closed calibrated collection drape, emergency hysterectomy for uterine atony. Because of our mix of etiologies, some women required emergency hysterectomy. There was just no way of treating them. But for us, an emergency hysterectomy for uterine atony was a failure of treatment. So we're trying to prevent women with uterine atony from losing their uteruses. We used morbidity outcomes, severe end organ failure, so that we were able to document these pretty objectively. Women had these or they didn't have them, and mortality. So in terms of condition on study entry, again, these were all women with shock. The women in the NASG phase had lost more blood by estimate, and objectively, more of them were in more severe shock, having a mean arterial pressure of less than 60. At that level, very little oxygenation is going on in the brain, so they're in severe shock. They're usually unconscious. As you can see from this, I point this, about 30% of women in the pre-phase had this severe condition compared to about 39% in the NASG. So statistically, a difference in terms of their severity of their shock. Cutting right to the results, in terms of measured blood loss, the women everyone started at shock, they started to get their blood loss counted once they were in the study. Women who did not get the NASG had about twice as much blood loss as women who received the NASG during the resuscitation, and this difference is statistically significant. And our major outcomes, emergency hysterectomy, morbidity, and mortality, again, we see very large effect sizes, all of which were statistically significant. So reducing emergency hysterectomy from 9 to 4%. It's quite a big difference. Reducing morbidity from almost 4% to 0.7%, less than 1% of women in the NASG phase had these end organ morbidities, and mortality reduced from 6.3 to 3.5%. Again, all of these differences were statistically significant. However, I do have to point out, that I think this is going to take me back. No. Women do die in the anti-shock garment. Okay, so it's not a miracle. It's not the thing that's going to the be-all and end-all, but the reduction in mortality is impressive. Right now, what those studies represent is tertiary care facilities. Those are referral facilities with blood banks, with surgeons, places that were able to save mothers' lives, even though women were brought in moribund from lower level facilities. What we're doing now is a cluster randomized control trial in Zambia and Zimbabwe, looking at the more important question, given the percentage of women who deliver outside of referral facilities, will transport in an NASG from a primary health care center result in decreased maternal mortality and morbidity. And we're doing this in Harare, Lusaka, and the Copper Belt of Zambia, and we have 38 clusters. We're in partnership on this with the World Health Organization and with a data coordinating center in Argentina, so it's quite an international level undertaking. Okay, so that's the data that we have to date. Again, data at the referral level and collecting data at the primary health care level. So what are the challenges? The questions were which systems have to be in place and what are barriers to the implementation? I think all of you will be able to come up with challenges, and I'm happy to discuss all of those and how we've been dealing with those. So some of the things that we've seen have been systems. What systems need to be in place for the NASG to work? There has to be access to PPH interventions and treatment and referrals. Putting a woman in an anti-shock garment at the village level and just leaving her in it will not save her life. She has gone into shock. She needs blood replaced. She may need surgery to stop the source of the bleeding. uterotonics have failed to get her uterus to contract. So she needs to be able to be referred to a place that can give her comprehensive emergency obstetrical care. Where are you going to implement this? Are you going to do it in a single site? Is the system going to get involved? Is the referral center going to be at the lowest point? What is the lowest point? Is it the community midwife? Is it the village health center? You know, where is the lowest level at which you can implement this and make a difference? Where's the financial support going to come from for the purchase of the NASGs and their ongoing training, use of them, and upkeep and replacement when they wear out? And Paul Labar is going to give us some of those answers. And how do you adopt this into standard medical practice and hospital procedure? What we've been talking about here about behavior change. Those of you who are clinicians know that as we're trained to have an emergency response to something, we get habituated to that emergency response. This is what we do. The first thing I do is this, then I do that. Suddenly I'm being asked to put this garment on. How do we change our behavior so that this will happen rapidly? And if we are implementing from a lower level of care, what's the mechanism for cleaning and returning an anti-shock garment to the first responders? And this is it a midwife, an ambulance driver, wherever you're implementing it at a lower level, the woman has to stay in that anti-shock garment until the bleeding has stopped and she's been resuscitated and she's stable. So you can't just carry her in wearing it and then take it off and take it back with you. And this is something that really needs a lot of work, and it's very, very contextual. There isn't one answer to this. It really has to be worked out given a lot of different circumstances. Barriers, someone's already said this, provider skepticism. In this case, people who don't have the skills and the supplies to save a woman's life get this garment right away. If you go to a village healthcare worker and ask her, would she use it, she will use it. If you go into the tertiary care centers and you ask a surgeon to do this first before he or she does anything else, there is so much skepticism, and that really has to be overcome to get people to use it and to keep it on. If you come in with a woman in an anti-shock garment to a place where they've never seen it before, and the surgeon wants to do surgery and wants to assess the patient, you may have a real problem. Who's going to implement it? Who's going to know what it is? How are we going to do advocacy and outreach? We talk about, a provider removing it prematurely, but what about a patient or a patient's family if they don't know what it is and don't know if it's saving the woman's life? The capacity to clean the NASGs and get them dried fast enough so that they can be reapplied to another woman. We have seen in some places, no countries named, that the providers who do see it in action and do see it working will oftentimes, I think misuse is wrong, but will use it prophylactically. I think this woman is going to bleed, so I'm going to put her in the anti-shock garment. There's no data on what that does. We don't know. And further, if there's only one anti-shock garment in the unit and you're using it prophylactically on a woman who maybe didn't need it, and the woman with the ruptured uterus comes in, what are you going to do? And then misperception of the NASG as treatment. The NASG is not treatment. It's first aid, stabilization. And what we've seen and documented is complacency. I'm calling it complacency in quotes. In all the studies that we've done, despite the fact that women in the NASG phase were often significantly worse, that is, more of them had lower mean arterial pressure, significantly fewer women received their resuscitation promptly, according to the protocol, in the first hour, what we sometimes call the golden hour in shock treatment. And here's our look at 502 women who had a mean arterial pressure less than 60, so 35% of our total. These are all women in severe shock. And you can see that they received less prompt attention once they were put in the anti-shock garment. They stopped bleeding. So they come in looking moribund. You put the anti-shock garment on and they regain consciousness, they're looking around, they're talking, and the blood has slowed down. So suddenly, providers feel like the pressure's off. And here's our evidence of that in terms of IV fluids. In the pre-intervention phase, 68%, 67.4% got the 1,500 milliliters of IV fluids in the first hour, and only 54.8% in the NASG phase. Blood transfusions, the same thing. We know in these countries and low resources, we're not going to have very many women getting blood transfusion in the first hour, but still, almost 46% got their blood transfusion in the first hour in the pre-intervention phase, and less than 33% did in the NASG phase. And again, these are statistically significant differences. So this complacency that I'm calling it, and maybe there's a better word for it, lulled into false security, anxiety level reduced, we need to be able to deal with this and really make people understand that yes, she looks better, but she still needs this definitive treatment. I think that's it. Did I make it? We're also concerned about our time.
And we're good.
Okay, great.
Thank you.
Thank you. And now for the new news.
Our next presentation will be technical updates on PPH technologies. It will be presented by Mr. Paul Lebar, who is a technical officer and project manager with PATH's Technology Solutions Global Program. He leads several multidisciplinary teams within PATH's Health Innovation portfolio, and his primary focus is integration of novel technologies into the areas of vaccine delivery, maternal health, and diagnostics for low-resource settings. He is also a project leader for an International Standards Organization Committee for Medical Device Standard Development. Mr. Lebar was awarded a certificate from the Regulatory Affairs Professional Society. He received a master's degree in medical engineering from the University of Washington and a Bachelor of Science degree in mechanical engineering from Northwestern University. Mr. Lebar.
Thank you, May, and thank you, Cathy and Pathfinder, for the kind invitation to speak today. It is so cold up here. I don't know if you guys know that, but I was thinking about asking Jen to borrow her sun because I would actually stay warm.
You didn't notice it was cold.
It's been a pleasure listening to the talks so far today because the background and the experience is so different from my own. That community level experience with the technologies is so rich, and it affords us a lot of learning to apply at the technology development end of things. So my background as an engineer is in medical device product development, and I'm here to talk about several technologies today, primarily focusing on the late stage developments in the anti-shock garment, focusing on making it more affordable and available, but also at the early stage, what we call the innovation engine, is an area where we've actually developed an exercise we called RAVE, the Rapid Assessment of Value exercise, that takes a look at the programmatic, the economic, and the technical aspects of new emerging technologies, and really weeds through many, many technologies, trying to isolate and move forward the few technologies that really make sense in all those three regards. So the reality check on the anti-shock garment was really brought to us about 2 years ago by Suellen Miller and other stakeholders who brought some of the challenges with the anti-shock garment forward to us, identifying the high cost of the garment, identifying the logistics issues, trying to get this garment more available and accessible, and then also, as indicated here, it's a little bit tough to see, some of the quality issues. This is actually a delaminated product that actually had not gone into use yet. So we were brought in to start looking at all of these challenges with the ultimate goal of reducing the cost and creating an affordable, high-quality anti-shock garment. So I want to talk a little bit and be very transparent about the process that we applied here, a process very familiar to people who do medical device product development and work with GMP. First, we did a fingerprint mapping of the existing garment. We wanted to understand what attributes of that garment were important to carry forward in new garments. We developed a device master record, which is the blueprint. I'll talk a little bit more about that. Went through a sourcing process, quality plan, and then today I'll share with you some ordering information on the affordable, high-quality garment. Again, going back to the what we call fingerprint mapping, really understanding the characteristics, the attributes that make the most sense and are most important to monitor in the manufacturing of a garment. And so to do this, you really want to start off with a risk assessment of what can go wrong. And of course, we had a lot of help from stakeholders who were using the garment in the field to learn about this. And so here we have some used garments that show tearing, delamination, discoloration. All of these things were important as we developed these fingerprint mapping tests. Down here, we actually did some conditioning in solutions of bleach, understand the degradation process on the neoprene. Here we have an image of some thickness measurements, as the thickness of neoprene varies quite a bit, lot to lot. And then here we have an indication of stretchability, making sure that these little dog bone samples that we test actually of the neoprene that are representative of the garment are there to apply that hydrostatic pressure to the lower limb and abdomen. Moving that process forward, we established the DMR, the Device Master Record, that technical dossier or blueprint. And this is one of 25 or more documents associated with describing to manufacturers the geometry, the materials, how to maintain that quality in the long term. We took that dossier out to manufacturers globally, identifying at first 63 potential companies that were through business-to-business networks, through our own collaborators that we've worked with for soft good product development and medical device development in the past. We narrowed these down to 53 that actually responded to our inquiry. 35 we deemed were qualified to receive our request for quotes. 13 were kind enough to provide us quotes. We quickly narrowed those down to 5 and then had those sign NDAs. We reviewed the RFQ and the drawings with those 5, received samples from those 5, revised quotes, and then after going out and inspecting 13 of the potential manufacturing facilities, we narrowed it down very quickly to 2. And then our work began on co-developing a quality plan with these final 2 selections, one in India, one in China. I'll talk about a little bit more later. That quality plan is designed to ensure that Path can ultimately back out of the process and that the quality of the samples that we received during this qualification process are the same that you, the stakeholders who will be ordering these garments into the future, that there is no difference and that there is very clear indication of where that bar is to set for the quality level. Here's a very simple flowchart that describes that quality process. What I really want to communicate here is that we did take a GMP approach to establishing how that quality, good manufacturing practices. And this quality plan links design and material controls that make sure that the manufacturers don't shortchange and order the cheapest neoprene possible. They order the right materials. Through the manufacturing process, they use nylon stitching, not cotton stitching, and then through order fulfillment. Our results to date, I'm really excited to announce today that we do have one fully qualified large anti-shock garment manufacturer out of China. We are still in the tech transfer stage. Having completed tech transfer, we have not yet qualified our India manufacturer. We do, however, have indications that they're very qualifiable, and we're excited to continue that process and move them forward, particularly to supply small anti-shock garments, which are more prevalent in use in Bangladesh, India, Peru, many of the countries where the studies have been ongoing. Introduce you to Blue Fusion. I do have ordering information available for everybody who wants to order, but Blue Fusion is the company. We did our due diligence. They happen to be a Hong Kong-based group, but the manufacturing is done in China. Here you have an indication of what their main income is. They make wetsuits, which was perfect because they have lots of neoprene on hand, and they have those connections to the Taiwanese neoprene suppliers. Here's how neoprene is handled in very large, almost 5-foot by 10-foot sheets initially. And these pictures really also communicate that this is not a rinky-dink operation. They actually have very nice facilities, very nice office space. So we were really excited. These are a well-established manufacturer that we're moving forward with. There are, however, as this is a reality check exercise today, several challenges. I mentioned that we're still working with the Indian supplier. Multiple sizes create a lot of challenges that I'll talk about. There has to be a very careful balance between demand, that supply side sustainability relies on demand, and the minimum order quantities and the lead times that I wanted to communicate a little bit about today. And then, as Suellen mentioned, the cleaning logistics and the protocols associated with that. I think there's a long way to go in those. Real quickly, briefly on Visco, there is a distinction between the photos that I showed of the Chinese manufacturer and this Indian manufacturer. That said, they have been extremely collaborative, and we do think that they are very much qualifiable within months. Their industry that they're involved with is actually more geared towards medical products. This is from their website. We actually viewed many of these technologies on hand in their showroom. They're manufacturing these in that space. And this is an example of one of the early samples that they sent us for the anti-shock garments. So we've been very pleased. They just are not as quick to move forward as our Chinese collaborator. I mentioned demand. We worked with an intern this summer from the William Davidson Institute who actually went into country and established the inputs and then built this demand model, which is very important for us because as we're setting up manufacturing, that's the first question the manufacturers want to know is how much raw material do I order? How many are you going to be supplying? Or how many are you going to ask us to supply, I should say. And so the dynamics, as shown here, actually is a compilation of both India and Nigeria. It's not global market dynamics. It shows a traditional S-curve with a significant inflection point here with around the same timing as the updating of the WHO guidelines that's anticipated with the completion of the randomized cluster trial. What's really interesting up here, unlike contraceptive technologies or other consumables, we're not talking tens of millions or hundreds of millions. So this is really considered a low-volume production product, and that really does affect supply. You'll see in the lead times, we're looking at lead times and minimum order quantities of roughly about 1,000 garments. The sizes. There's 3 different sizes. There's been some color changes in the past, but I think it's important to point out that we now only have a large NASG anti-shock garment manufacturer at this low price of $55. We are still working to establish a small manufacturer. Actually, before I go into this, I think one way forward to balance that demand, minimal order quantities, and the supply or the size supply is to really differentiate between manufacturers and keep the Chinese manufacturer making larges only, and then they can focus on that while an Indian supplier works on the smalls. It's, I think, a really good way to ensure that they each have the highest amount of orders for what they've specialized in. So this was a photo that came to us by way of Pathfinder in Nigeria, and it shows that these garments are really subjected to some extreme conditions, whether that's ultraviolet rays or bleach solutions. And we actually observed between the instructions for use and what was actually in practice 4 different bleach solutions, each one off by a factor of 10 that were being used. And then even if you do have some agreement on that solution, then you have fairly low-paid workers who are actually doing this cleaning, and you're asking them to do pretty high-level math for a dilution set. So some of these challenges need to be addressed. I think one way forward is to actually do a validation study on the minimally destructive cleaning methods that can be done through a third party to show that they're effective, identify what that bleach solution should be, and also evaluate other solutions that might be on hand in these community-level programs for cleaning. And then perhaps supply with the garment 40 little tablets of that cleaning solution that need to be dissolved in several gallons of water. Might be one way forward to make sure that the right protocol is used each time. Again, going back to that rapid assessment of value exercise, before we got involved with the anti-shock garment, we wanted to make sure that we were getting involved with something that made sense to us. So we conducted this programmatic economic and technical exercise. And really through that, we identified two emerging technologies that also deserved more look. These are the balloon tamponade and also hemostatic agents. So many of you are familiar, and it's been mentioned today, the balloon tamponade has a couple of different configurations in Bangladesh, Ghana, many of these countries. The most frequent configuration, and there is clinical evidence to demonstrate, there's a publication that shows 43 cases of this being a life-saving technology, but it is an improvised technology that's made of a condom tied onto a catheter, and then in this case the actual pressure is supplied by a water bottle. This is a very important technology. We want this to continue on at an improvised level, but it is not something that big aggregated procurement agencies can get behind. USAID, UNFPA, UNICEF cannot buy this, and therefore I think, in terms of the scale up globally, there are limitations here. And so at the other end of the spectrum, you have a device that's frequently found in North America, Europe, costs $77 for single use. And that's at the low end of the spectrum. The more expensive ones are about $200. We see a lot of opportunity between these two to develop something in the sub-$10 range. Some countries that's still going to be a challenge. It might have to be sub-$4 or sub-$3. We think this is achievable. In order to get the aggregated purchase, it really does need to be done under good manufacturing practices. It needs to be following ISO international standards for medical devices, ISO 13485, and go through a qualification process. So we're excited about this technology. A couple years off to get to that $10 or sub-$10 level. I'm hearing about technologies that may be available in India for that. I want to talk to some folks about that while I'm here today. But we're excited about this. Equally excited about hemostatic agents, probably a few years behind where balloon tamponades are, but there's some really strong indicators in this area I want to mention before I wrap up, and that is that hemostatic agents have gained widespread use for pelvic surgery, specifically because they're good for use in areas of difficult accessibility. Briefly mention how these operate. They use a clotting factor, sometimes fibrinogen, collagen, to actually trigger that cascade of events that lead to clotting, and they do it very rapidly. Now, there's been a couple publications on cervical lacerations, on placenta previa, use of hemostatic agents in the last 10 years, but I think most excitingly is this 2007 publication using a Baxter product called FlowSeal that actually achieved, reportedly, hemostasis almost instantaneously. Very exciting. Some of these agents, we've really isolated about 3 out of about 30 or more hemostatic agents. We've identified 3 that we think are very promising. And the work left to be done are with the mixing and packaging. How do you actually deploy this properly, the right amount, at the right time, in the right place? And then price negotiations. These are very expensive, but we think that there's a big discorrelation between the costs to manufacture and the prices that they're available, and we want to really leverage that. Being in the business of discovery of new technologies, I really want you guys to envision what is possible here. We believe that with current technologies, there is this possibility of delivering a foaming agent hemostatic carrier that would actually fill the void of the uterus, providing hemostatic pressure against the bleeding site and delivering this clotting factor. And then to take it one more step forward in the visioning process, that could be bioabsorbable, so you don't have to remove it, which was the problem with a lot of the packing, uterine packing, was removal of agents that were causing rebleeding problems. So we think that something can be done that would be bioabsorbable as well. Very briefly, I've got flyers by the table in the Pathfinder table right out here. If you want to pick these up, if you want to talk to me, I'd be very interested in helping people who are ordering the anti-shock garment consolidate orders so that we can get the most effective and efficient logistics to get them in country. We do have a minimal order quantity of 1,000 right now, which seems like a lot, but if you consider that these are roughly a third the cost of the original ones, you'd be paying the same price for only 300 of the original. So with that, I'd like to acknowledge the PATH team, the consultants we've worked with, our collaborators, particularly Suellen Miller and Pathfinder, both here in the States and in India and Nigeria, have been very, very helpful. Some interns that we brought onto our team, and also the donors who've been involved with scaling up the affordable, high-quality anti-shock garment. So thank you very much.
I'd like to thank these researchers and all of you who do research out there for the technologies and for the perseverance of these researchers. This, when did you start your first research on the NASG?
2003.
2003.
I'm still plugging away.
And still plugging away with much persistence. And I'm not sure if all of you realize for us, Paul's announcement about a cheaper NASG is so exciting and such a change. For those of us, when we started working in India, we realized that the NASG that we were using in Nigeria, which was a large size, in no way fit Indian women. When they're put on, the leg wrappings go around twice for Indian women. So that meant a prototype for us for India, which cost us at the time $170 per garment. So for us, this news and this announcement is really exciting. So questions, either reality checks from the panel or from the audience. Questions? John.
John Townsend, Top Counsel. Paul, that was a terrific explanation of kind of using technology, a focus on improving access and affordability. Have you guys been working with the Reproductive Health Supplies Coalition? I'm with someone from PATH. I'm part of a new and underutilized coalition caucus, and this looks like an underutilized technology. And one of the things we do is kind of figure out how would you get, if you're having low numbers, why would you take you get an intermediate to buy for Southern Africa? And then you begin to get issues of scale and cost take on a whole new dimension. I think if you think about getting out of the traditional procurement way, moving it through Reproductive Health Supplies Coalition, looking at credits and other things that they have available for other family planning supplies, I think you may find a window to bring that cost down another 20 to 30%.
I appreciate the question. We've looked into this. We're in the final editing stages of a global regulatory report, which I can make available to anyone here. We've looked into this, and yes, we do work with the Reproductive Health Supplies Coalition. Our procurement team at PATH does, and we're very actively working with WHO and UNFPA. What we found out with regards to the anti-shock garment was actually extremely disappointing. Based on the low numbers. We were very hopeful originally that there would be this cascade of events with the randomized cluster trials moving into WHO guidelines, updates for postpartum hemorrhage. We looked at, traditionally with contraceptives, then you have a WHO qualification process and then UNFPA kits and UNICEF books are updated, and then it becomes this ability to do an aggregated purchase of many and then disseminate them from there. The volumes of these, as I pointed out, are so much lower than contraceptives. They really fall out of the traditional protocol that I just described. And so what we're looking at is, unfortunately, that aggregated purchase might never extend beyond WHO update of their guidelines. And it's very, yeah.
Technology. So I think continuing on
Yeah.
advocacy in that area is really important. Otherwise,
Yeah.
we'll be giving out old technologies at huge volumes for the next 20 years,
Yeah.
and there isn't any room for any innovation.
Yeah. Well, we're all behind the advocacy. We're realistic about what we can do through UNFPA and UNICEF, and it is unfortunate.
Koki.
Thanks. I have a question for Jennifer. Maybe he can go back to sleep when he's talking.
I don't think so.
But I wanted to ask you about your comment on early liberal treatment. And I was wondering if you could share a little bit more about your thinking in terms of when we have so many deliveries that are happening outside in the home setting, where we are not able to reach those women with prevention. How would we be able to take early liberal treatment out to those women so that they recognize that they need treatment and would be followed up?
I would love to let Suellen answer that question since we're partnering with her on this project.
Thanks. That's a really good question, Koki. The way we're looking at the study is a study of service delivery options. So one model would be training A&Ms or training the person at the home and sub-center level. We're starting the study in India to do prophylaxis, universal prophylaxis. So they're supplied, and they have a relationship with a primary health care center with a district hospital. They're all trained to prophylax. With the early treatment model, the extra training is identification of when is too much bleeding. In this case, 350 mLs is what we've decided we'll do the early treatment at. So in one model in India, we'll be using the drape used with just a thick line at what 350 would be. In Egypt, I think we'll be trying to use the blood mat that Shabnam showed. So there has to be something, it could be a conga, but the training will be at this point, this is when you treat. Does that answer the question?
The thing that I don't understand about this, because it sounds great, is particularly on the community-based piece of it, how are you actually reducing costs? I mean, whether they do prophylaxis or whether they have it for treatment, you've still bought the drug, it's still the same amount. I mean, if it's out of facilities, then I can see, because they've got a supply, they use it or they don't. But I don't understand how, so I'm sure you all have thought about this.
Yes, we've thought about it, and I can't remember if I saw you in Seattle for that meeting that Genuity and Gates did. You were there. I gave a presentation where we actually modeled it with computer modeling, and the difference was millions of dollars for one state in India. If you give a dose to every single delivering mother of prophylaxis, 3 pills, and then you wind up needing early treatment for maybe 10 to maybe 25% of all delivering mothers in another arm, the cost difference is huge. I didn't know what the question is. I thought that was it.
No, but then, okay, if you're out in the community, so you've got women who are in the community, they're not coming to the facilities.
Right.
You've got to give them the drug one way or the other. Either they've got it in case they need it for treatment, or they've got it for prophylaxis. So,
Well, this was distribution to healthcare providers, not to women.
so you're not talking in the community. Okay.
Yeah.
We're talking in the community, but
In the community, but to healthcare providers, not directly to women.
Okay.
Yes. Yes.
Jennifer, thanks very much. That was a nice summary. I wanted to tie in something that Deborah mentioned about a study of the quality of oxytocin, and I think everybody's heard examples of providers giving 2 or 3 doses each time. I just wonder, with all the studies, what that's going to have impact that has on clinicians treating or doing for prevention. you know, the idea that maybe the oxytocin that they have isn't as good a quality as it should be or as it's used in the trial.
You're asking me to speak about the quality of oxytocin. I'm not.
Well, no. What I'm getting at is, Deborah, you mentioned a study that's coming out soon about quality of oxytocin in facilities, and so the question is, if there's doubt in a clinician's mind about the quality of oxytocin, you know, what does this is so taking it away from a clinical setting, what impact does that have on sort of on treatment protocols and regimens that a clinician might follow or a physician might follow?
Well, I'm not familiar with Deb's study, but I can say that I believe, well, we talked a long time ago about it anyway, quality of oxytocin. I thought Jeff Spiller said there was even a heat stability study, but what we've seen even everywhere we've gone is there's lots of oxytocin that's kept outside a refrigerator, and yet people are using it, and then you go around and they say they haven't had a PPH in 20 years, you know, so I don't know necessarily if, you know, I don't know necessarily that maybe oxytocin being outside of the refrigerator and maybe being lower quality is in itself a reason to say that the providers aren't going to use it. I don't know. You have to speak a little bit about your study, Deb.
He's got a good question. We don't have the answer, and I think we need more evaluation of quality of. I think we've got some issues around ensuring kind of the pharmacovigilance of oxytocin, but I think we need to wait for the study to come out and discussions to be held at this point in time, because it's probably a little premature.
One thing I can say about sort of looking at the two technologies together, which is something we're planning to do, for instance, in Vietnam, looking at Uniject and misoprostol for prevention, is that even our partners, the Ministry of Health, they have a lot of oxytocin available, and they're very, you know, keen to continue using oxytocin, but even they recognize that in more of the rural, remote areas of the country where maybe there are fewer deliveries or they don't have such a regular supply of oxytocin, that those might be the places the ministry might choose to select misoprostol to avoid some of these issues, and then to make oxytocin available in more of the periphery areas. And that sort of speaks to, I think, what I was getting at in my presentation about how the two technologies, you know, are going to go together, I think, in a lot of settings.
Yeah, Farouk.
I just want to make some comments about the complacency factor you talked about in the NASG group. I've certainly had a lot of discussions with providers in Nigeria, and because I've noticed the same thing. And it comes, you know, across very strongly that the providers are actually, you know, deliberately being complacent when they place the patients in the NSG. And the reason is there are very, very few providers out there. I was just discussing with Susan before we came in here. You see one midwife taking care of 20 women in labor at the same time. You know, so once she's got a bleeding woman and she puts her in the NSG and she believes she has got it under control for that moment, then she moves on to treat the other woman who is convulsing with eclampsia. You know, and despite that, I've tried a lot to make them understand that this is indeed, and I think they understand the situation. They do understand that the woman needs further treatment, you know, but for them it's a good thing that they have got at least some time, you know, to do other things before they come back to this woman.
Right. Well, Farouk, maybe that's partly a reality check too. I mean, I was with you in the field, and how many, if you take Murtala Mohammed Hospital that does 1,000 deliveries a month, and several delivery wards, but how many midwives per ward for how many patients?
In Murtala Mohammed Hospital, which is easily the largest, you know, maternity in Nigeria, they do, as you said, about 1,100 deliveries in a month, and they have on their maternity ward, they have 17 midwives in all. So for the morning shift, you have maybe about 3 or 4. For the afternoon shift, you have 2. And sometimes on the night shift, you have only 1 midwife.
Yeah. Which is also why Suellen mentioned that sometimes these providers it's not that they just think somebody's going to bleed. They recognize also how fast women bleed out, especially who are really anemic. So they will put the garment on. especially if somebody's had antepartum hemorrhage. They say, we know she's going to hemorrhage. And they do put it on a little earlier, but I don't know. Farouk, I don't think you would disagree with what they're doing, right?
It's difficult to disagree when you know all the challenges that it is.
Right. Yeah. The complacency that I noted was in hospitals that actually had staff, because we were doing it at the tertiary care level. But I think that this point is a really good one, and maybe having more garments, getting 3 garments for the price of 1, may make a difference in having them. It won't solve the problem of more staff, however, which is serious infrastructure.
We're in New Jersey now working, so.
Susan.
So I think also Suellen noted in her field work that also, and hopefully it doesn't happen very frequently, this additional use of the NASG for women who haven't yet delivered the baby, and because bleeding starts to be a problem, but providers being so desperate for something that will help, that putting it on the woman's legs, which is actually an inappropriate use of the NASG. Right? Isn't that correct, Suellen?
Well, I think we don't really know what happens if you put it on the legs of a woman, let's say, with placenta previa. She has a living fetus. If we put the abdominal segment on, we know we would decrease blood flow to the uterus. But we don't know if we just put the leg segments on, are we doing harm or good? Are we shunting blood to the uterus and actually increasing the bleeding? There are a number of things that we don't know. A lot of the studies that we're doing now in partnership with UCLA are looking at just some of these issues. But again, it takes a while to find out answers.
Yeah.
Yes, Hadi.
Okay, thank you. Well, first I must say that it's really a pleasure to see researchers and program implementers and donors in one room discussing the same issue. I think that is really one of the remarkable global commitment to address postpartum hemorrhage. So I'm congratulating the speakers or everybody who is really involved in this. This is really fascinating panel about talking about more anti-shock garments that are going to be in the market with much less price, and that is one of the exciting areas which is really make the situation in the field move up forward and fast, and that is one of the problems that we face when we go in the field. The other thing I really also I must admire the ethical cautioning of Suellen about not to push for using anti-shock garment without being really aware of what are the consequences on that. In Tanzania, for instance, we faced a situation where we had to go beyond the catchment area outside the box because we were concerned about, we trained all the providers in the health facility in the air catchment area, but we realized that one of the facilities may send the referral cases with anti-shock garment to a referral hospital that is outside the catchment area. So we had to go to and train the health providers outside the catchment area because we were concerned about they may remove it immediately and then that might have other consequences. So I think that's kind of cautioning. It's really highly ethical way on appreciate that too. And thanks.
Thank you, Hadi. Any other questions? Yes.
Sharon R. Scott Mills with IntraHealth. I just wanted to build on a comment made a few minutes ago by Jennifer. In Nepal, they've actually decided to use misoprostol prophylactically as a community approach, but they call it the remote area strategy because so many women don't have access to a trained provider, and it's still, under 20% delivering in institutions. So the ministry really has been proactive in making that decision. So just to build on what you were saying a few minutes ago.
Thank you. Okay, we are right on schedule, I'm pleased to say. And so we have 1 hour for lunch. Lunch will be served across the hall. Suellen, did you have another question? Sorry?
I forgot
Go
to
ahead.
congratulate these guys.
Yes.
It's a great panel. So I was feeling that.
Thank you. Thank you.